What I want to try and do is, like Bo said, give a briefing from the standpoint of essentially the medical perspective. And so as a little bit of background, I've known and worked with Bo for a long time, have a background in sort of the hacking culture and world of folks who go to places like DEF CON, which is how we first met, but I'm also a practicing anesthesiologist. So I am somebody who works with ventilators on a almost daily basis in the operating room and in the ICU. So Bo asked me to give a quick little briefing here because I understand that a lot of you are interested in collaborating on projects. See our whiteboard here. So that looks good. So what I want to try and do is, like Bo said, give a briefing from the standpoint of essentially the medical perspective. And so as a little bit of background, I've known and worked with Bo for a long time, have a background in sort of the hacking culture and world of folks who go to places like DEF CON, which is how we first met, but I'm also a practicing anesthesiologist. So I am somebody who works with ventilators on a almost daily basis in the operating room and in the ICU. So Bo asked me to give a quick little briefing here because I understand that a lot of you are interested in collaborating on projects. Oops. Can you guys still hear me?
Yes, sir.
Yes.
Okay,
Yes.
good. And can you see the whiteboard that I'm showing right now?
Yes.
Okay, great. So we're going to do kind of a basic overview for those who are interested in collaborating on these types of projects about respiratory physiology and ventilator physics. And I appreciate you bearing with me a little bit. This is kind of an impromptu talk, which are always a little tougher to give than formal lectures. And it looks like my stylus on my whiteboard isn't quite working out here. So let's do respiratory physiology and kind of how ventilators do what they need to do. So a couple of disclaimers, as earlier mentioned, I am not an engineer. I am also not a physiologist. So if we had anybody who was a PhD physiologist, they would probably laugh at a lot of my explanations because some of the concepts will be a little bit on the simplified side. And I also want to make it clear that as I'm not a biomedical engineer, I don't want to make hardcore recommendations for what you guys should or should not be looking to build. But I also don't want to discourage anybody who is interested in contributing to these problems by overwhelming them with kind of everything that's involved in this workflow. It is an incredibly important device and it's very complex, and I'll show you that. And so I think I might be able to help kind of frame what the art of the possible is and what could be very useful in the setting of the workflow that we might be experiencing when we start seeing kind of the surges of the people needing support. So just some basic objectives for today. I want to kind of go over a little bit of physiology. I want to talk a little bit about what COVID lung disease really does from the standpoint of affecting that physiology and how oxygenation through a ventilator works with that. So I want to talk about ventilator concepts. I want to talk about the physics a little bit, the workflows, and then go over kind of what I think the ideal maker ventilator might look like. So I know that we all probably remember from health class in middle school, kind of basic overview of anatomy, but starting off kind of with how do we breathe and perform respiration. Obviously we have airways. So mouth is up here. Soft tissue of the larynx turns into the trachea. The trachea is kind of demarcated by vocal cords. So moving in air and out with the vibration of the vocal cords obviously helps us phonate. But then as the airway turns into the smaller airways, we have these branching elements that we call bronchioles. And as things kind of get smaller and smaller. It's kind of one of those fractal patterns where we end up having almost tiny microscopic small airways called bronchioles. The terminal aspect of that bronchiole is a piece of tissue called an alveolus. And what the alveolus is it's kind of a tissue that is bound by pulmonary blood vessels. So when air comes in, there's oxygen molecules. Those oxygen molecules are allowed to interface. So here's alveolus. We have oxygen that we breathe that diffuses across pulmonary cells, interstitial cells, and then can be picked up in the bloodstream. So you have tiny little blood vessels that are surrounding this alveolar tissue. This blood is flowing from the right side of the heart. It is deoxygenated blood. Whenever you have a blood vessel flowing away from the heart, it's called an artery, which is a little counterintuitive in this case because we normally think of arteries as carrying oxygenated blood, but the blood that is poor in oxygen but rich in the metabolic byproduct CO2 that flows here. And then from a concentration gradient standpoint at the level of the alveolus, oxygen flows from high concentration to low concentration. So blood and the hemoglobin in blood picks up oxygen and drops off CO2. So this is basically respiration. So respiration has two components to it. That's what we call ventilation. So that occurs simultaneously, which those of you looking at things will remember that, because when we talk about ventilators, we have to accomplish both of these goals. So both oxygenation and ventilation. From a sort of physics standpoint, we know that our lungs inspire and expire. And so basically what happens, so these are lungs. When you inspire, you have a big muscle called the diaphragm. And you have intercostal chest wall muscles. When you inspire, these muscles move in such a way that the total volume of the thoracic cavity is increased, which has the effect of, if we consider ambient atmospheric pressure, let's call that 0, it creates a negative pressure situation because you have a larger volume with less gas in that volume. So there's a negative pressure, and that's what pulls air passively in into the lungs during inspiration. With expiration, opposite concept. Your muscles contract and recoil, and there's an inherent elasticity to the chest wall that increases positive pressure, so forcing pressure out through, forcing gas out through the mouth rather. So this is normal respiration. And we refer to that as negative pressure ventilation, because we generate that negative pressure gradient that pulls gas into the lungs. So this is how we breathe from a physiologic standpoint. Everything with ventilators and mechanical ventilation in today's age is positive pressure ventilation. So an important concept is that the use of a ventilator in clinical situations is inherently a non-physiologic way of performing gas exchange. We used to have negative pressure ventilators. People who are old enough might remember in the days of polio, iron lungs. So iron lungs worked in a similar principle wherein somebody was in constant pressure chamber, which then generated a negative pressure to force air into the lungs. So that's essentials of normal respiration. A couple of other concepts that are important from the standpoint of talking about ventilators is talking about essentially volumes of the lung. So on the y-axis here, we have volume, and we look at essentially time this way. And Normal breathing occurs in something that we call tidal volumes. So tidal volume is an important term, and that's essentially the amount of gas that is moved in and out at rest in basic sort of passive inspiration. We have obviously the ability to take very big deep breaths and hold our breath and blow out and force a lot of breaths, a lot of excess volume in that standpoint. So that is referring to the ability of our lungs to put out max number or max amount of volume is referred to something called the vital capacity. No matter how hard you try, you will never be able to fully exhale all of the gas that's in your lungs. There is always a residual volume. And then there's a number of combinations of these different terms and volumes. You have your functional residual capacity, which is derived from your expiratory reserve volume. So there's a lot of really complex pulmonology concepts that you can get into, but the basic thing that's important for most of us when talking about ventilators is this concept of tidal volume, which is sometimes abbreviated as just volume, and that's the amount of gas that's being pushed into the lungs.